Lay still, okay? Our patient is having the Deuk laser disc repair performed at L5-S1. Now he has prior fusion done at L3-4, L4-5. I'm going to give you some numbing medicine. Just lay still. You can see how some people's tolerance, even just to an injection with a little needle, can be not so great. We're just infiltrating. It's normal. I'm going to numb him up for his rhizotomy as well. Now, this patient has two problems. The first is adjacent segment disease at L5-S1. He basically has a annular tear with herniated disc at L5-S1. Worse on the left. I'm going to give you some numbing medicine in a minute, okay? Shot. And that's what we're aiming for, is that L5-S1 disc below the fusion. You can actually see that there are screws and rods that were put in. We did not do that at Deuk Spine. That was done elsewhere. And this poor patient has been living in pain for years because of what's called adjacent segment disease next to the fusion. He did not want more fusion. He discovered the Deuk Spine Institute online. His wife did. And here they are to get some treatment. And so he's a little wiggle worm. But we're going to do our best. Shot, Jordan. There we go. We're making our way down south to L5-S1. I feel a lot of scar tissue. Shot. Lay still. Shot. You're doing great. Give me an AP. So I'm navigating the needle, spinal needle, down to the spine. I want to enter the spine right where the herniation is, on the left side. That's not bad, actually. Thought it would be a lot worse. I have about a 2 millimeter area that I'm working in. The needle itself is 1 millimeter, so I don't have a lot of room. Are you comfortable? Shot. All right. Shot. My gosh. Got lucky. Really lucky. Shot. Let's see where we are here. That looks pretty darn good. I'm happy with that. Don't move. You're doing great. So, got lucky. I mean, the space that I have to work in with this is incredible. Just All right, before we do anything, let's just talk for a minute. Let's go back to the AP view. I want to show the viewers. L5-S1 is the hardest disc in the world to fix in the lumbar spine endoscopically, especially transforaminal endoscopic, which means going through the foramen, which is what I've done. There's virtually no space. You can see the bone of the iliac crest. Let's show them that. Yep. See how you have to slide right past it? And then you have to go through the foramen. And I think we could do a better job with that view. But show them the sacrum right there to the left. Up. That up a little more. That black line right there. You're touching it. Slide to the left and right. See that black line? That is the sacrum. It's bone. You cannot go below that. And I think we have to angle the fluoro a little bit to show the true path. But the point I'm trying to make is simple. There are not many surgeons in the world that do L5-S1 transforaminal endoscopic surgery, and probably, if not the only one. Now, show them this top of the sacrum there. Now you can see the space I have to work in is very small. All right, and we have to come in, you know, in the safe zone, which was first defined by Parvis Campbell. Don't move! Parvis Campbell was the first surgeon to describe this approach. And what approach means is how the surgeon gets to the body part. So if I'm going to take your gallbladder out, then it's the approach to the gallbladder. It's this where I put the incision under the rib, how big the incision is, and how I get there. All that's called the approach. And the approach to the L5-S1 disc is the hardest in the lumbar spine. So hard that there's no other endoscopic surgeons, there's only a few in the world that actually even try. Most of them go interlaminar, which means they're going to go between the spinous between the lamina, and that's a big mess because you got to remove ligaments and bone. So the transforaminal L5-S1 is rarely done, but we do it all the time here at Deuk Spine. There's a way to do it. It takes a lot of skill and experience and going just in exactly the right spot. And sometimes it's very difficult to get to. The reason I'm telling you about this is for future spine surgeons, don't give up on 5-1. Figure it out, understand the anatomy, and you know there's going to be a couple that you won't be able to get to, but the vast majority you will. And it's important because L5-S1 is the second most common herniated disc or degenerated disc that causes pain. Lay still. I need him awake though. You're good. So this L5-S1 disc is the bottom disc in the spine. His fusion is above it. He has a solid piece of bone here where he fused, you know, the L3 to L4 to the L5 with screws and rods, okay? And the reason why this surgery is harder than normal, because L5-S1 is already hard, is because all the bone graft back here from his prior fusion has made it challenging for me to get into the L5-S1. Don't move. Lay still, or I'm going to have to tell your wife. Okay? Are you comfy? All right, he's listening. Are you comfortable? I need him awake. Good. I need him fully awake. Now, when I looked at this patient for the first time, he showed me, I said, where is your back pain? And this is what he did. He said, right here, right there. He literally pointed right here. That's the L5-S1 disc. And then he said also over here. Well, what's over here are the facet joints. That's the L5-S1 facet joint. Don't move your body. Lay still. Okay? You're doing great. Everything's fine. We're going to put you to sleep soon, but I need you to lay still. So we're going to be treating the facet joints next with the Deuk plasma rhizotomy. You're not going to see that today. We're going to show it to you in the future. But you are going to see the Deuk laser disc repair. Are you comfy?
You said yes.
Good. Why are you moving around so much? Just lay still, all right? We're going to put you to sleep soon. Any pain? Any pain you have? Do you have any pain? No. Good. How bad is that on a scale of 1 to 10? What was the highest that went to? Unfortunately, he's not the most cooperative patient.
What do you say? 7? 7.
Is that where you typically get back pain? All right, we can put him to sleep. Good.
Yes.
All right, so we have 7/10 concordant L5-S1. Remember, we're fixing the torn disc, which is causing his back pain, but we're also going to fix the facet joints at L5-S1 because he has bad arthritis in there, and that's causing pain as well. All right, we're going to put you to sleep. Just relax and count out loud from 1 to 100. All right, so while he's going to sleep with the anesthesia, we use propofol sedation through the vein, and our anesthesiologist will administer that while our nurse and our anesthesiologist monitor his oxygenation and ventilation and airway. We're going to go ahead and place our guide wire. We're going to next make our incision. Don't move around. Now I'm going to tell you something about patients like this that have chronic back pain. First of all, they make the big mistake of having fusions done when they don't need them. But the surgeons they go to don't tell them anything otherwise. So the surgeons tell them they need fusions, But that's all the surgeons know how to do, unfortunately, so that's why they get fusions. Or they go to pain management, and they're told they need shots, epidurals, and needle procedures, and all kinds of things that don't work, and they end up in pain management for years and years. So then what happens is these patients start to what's called self-treat. And what self-treating means is they start to take medications and drugs that they can get their hands on that help ease the pain. And the reason they're doing that is because they're not getting adequate pain control from the doctors. So this patient, like many, has had a history of self-treating, which I won't talk about in details, but these self-treating techniques are not safe, you know. You might think they're safe, you might even recognize some of them. For example, alcohol. You know, drinking alcohol every day to eliminate the pain and live with the anxiety and misery of being in pain. That's not a good way to fix this. It doesn't fix the problem at all. It just makes you addicted to alcohol and have all kinds of problems from alcohol. Or it could be marijuana that you do. Or it could be pills, pain pills, like oxycodones, okay? I'm not saying this patient does any of those things, but I'm saying that happens all the time, where the patients are unfortunately get addicted to really bad treatments. All right, there's a lot of scar tissue here, and I'm moving past it. This is scar tissue from his fusion, and I'm trying to get past it safely, and so I'm actually going to be advancing this thing along the guide wire. You can see he's wiggling just a little bit. He's not awake. He's actually asleep. However, his body is just responding by doing a little jiggly wiggly. That's all reflex. What? Yeah, you can turn the laser on. Now, there are very few places in the world that actually use the laser for their spine surgery. We do at Deuk Spine because we're actually probably one of the only ones that actually use a laser. Other people might say they use a laser, but they don't actually use it. Wait, let me see. Shot? No, not yet. But the whole surgery we do is done with the laser and cannot be done without it. Shot? I think that's okay then. Hold on, let me just feel it. Don't move. How you doing, doctor? You want me to wait? I'm okay. If the movement is what you need to be safe, yeah. Let me see.
I was about to say that.
Shot? I don't mind the movement. I know it's reflex. Go ahead and take it. He's a little bit lighter than I want him. All right, we're in where we need to be. Don't be bothered. If I were to pinch your toe while you're sleeping at night, you would wiggle your body a little bit to get away from that pinch. And that's all we're seeing. So he's not experiencing pain on a conscious level. He's unconscious and asleep, but his body is trying to get away from painful stimulation, which is natural and normal. It's mediated by your spinal cord and your brainstem. It doesn't reach conscious levels. All right, so we're advancing our tube into L5-S1, and now we are inside the L5-S1 disc. We went right through the tear in the back of the disc, and we're going to remove the herniation out of this disc. And we're going to clean the annular tear to get rid of his back pain. Feel free to ask questions, folks, while you're watching these surgeries. We stream them live so that you can participate with us during the surgery and ask questions. Just to reiterate, in this particular patient, his pain is coming from two sources. The first being the annular tear in the back of the L5-S1 disc. The second being the facet joints. Take your time. How's he doing, doctor? Okay. Good? All right. Well, I think we've gotten through this more stimulating part of the surgery. And we'll hopefully now... I'll be happy to do that. All right, so we're going down into the disc. There's the disc. There's some pieces of herniation you can already see. Yeah, pretty scarred up from chronic inflammation. But we are going to fix this, and he's going to be happy when we're done. I'm sure of it. These are all pieces of herniation that we shoved back into the disc through the tear. This technique is called the inside-out technique. It was developed by surgeons ahead of me that I learned from. One of them most notably being Dr. Anthony Young. Tony Young, goes by Tony Young, who taught me a lot about lumbar endoscopic surgery. Unfortunately, Dr. Young never did cervical or thoracic, but I learned everything I know about lumbar from him. And then, of course, I taught myself quite a bit and modified the technique that he taught me, and ended up developing my own technique, which was, I think, better. Better for several reasons. Most notably that I don't treat just leg pain, I treat back pain as well. So most endoscopic surgeons only treat leg pain, leg weakness, numbness, and tingling. But with the Deuk laser disc repair, we go beyond treating just leg pain. We include the treatment of the back pain as well. Patients that come here almost universally have leg and back pain. So they need both fixed. And if you tell them just your leg pain is going to be fixed, they'd probably be happy with that. But if you're able to fix their back pain and their leg pain, then they're going to be really happy about that. And we intend to do both. Everything all right, guys? His disc is very firm. I mean, this is very abnormal, huh? Yeah, I would say it is definitely an old injury. Thank God for this big laser fiber. We're able to efficiently do the work we need to do. Everything okay?
Yep.
Luis?
Yes, sir.
We like the giant fiber.
Huh?
We like the big fiber. It makes it go quick.
It's better for the patient.
We have a question.
Sure, I'm happy to take the question.
This comes from SARP on
Spent too much. Well, go ahead.
This comes from SARP on YouTube,
Hello, Sark.
and they asked, "Can you show nerve root?"
Can I show the nerve root? Yes, I could, but I'm not going to because it would require that I stop my surgery and show you the nerve root, and that would disrupt the surgery too much, and I didn't want to do that right now. I need to stay focused on fixing the patient. So I'll try to show you the nerve root in the neuroforamen. There's two nerve roots. One is medial and one is superior to where I am. This is called Cambin's triangle, named after Dr. Parvis Cambin. If you look at your textbooks or Google, you'll see Cambin's triangle is below the exiting nerve root and lateral to the traversing root. It's called the safe zone because it is safe, and there's no nerves in this area, and that's where we're working, is the safe zone. That was first described by Dr. Parvis Cambin, aka Cambin's triangle. Safe zone. The nerve root will be at 9 o'clock. If you can look at where we are now, those are all pieces of herniated disc coming up, by the way. So if you look at 12 o'clock, that's where the traversing root is, and at 9 o'clock outside the tube is where the exiting nerve root. In this case, it would be the L5 nerve root at 9 o'clock and the S1 nerve root at 12 o'clock. Great question, by the way. Can already see we've removed some of the herniated pieces, so you're getting a empty area. A lot of this is chronic. You see the gold color? It looks like a golden color. That's calcium, specifically called dystrophic calcification within the scar tissue, created by the inflammation from the herniation and the annular tear. All right, why don't we show our audience, why do people with herniated disc, bulging disc, degenerated disc, why do they even get back pain from their disc herniation? What's the cause, the mechanism? Okay.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. So now you understand why herniated discs cause back pain. Specifically, it's a tear in the wall of the disc called the annular tear. It must be in the back wall. It will not hurt you if it's in the side wall or the front wall. It must be the back wall. That's where there are special nerves. They're called somatic afferent nerve fibers. They allow for the transmission of very localized pain, which is what we treat here with the Deuk laser disc repair. We don't treat unlocalized pain, we treat localized pain. And the pain comes from the actual tear in the back of the disc, okay? That was discovered here at Deuk Spine Institute. We're the first to do it in the world, and we published it 10 years ago. If you look up the Deuk laser disc repair on PubMed, you'll find our publications. So I'd like to say a few things. First of all, our first patient is doing very well. He told me he wants to go play tennis right now. And he's from New York, as we said earlier. He's going to be ready to go soon, and we're going to go check on him. And if he's doing well and up to an interview, maybe we can do an interview in the recovery room before he leaves. So I'm going to go talk to him in about 10 minutes, 15 minutes, see how he's doing. That said, the other thing I want to say is I got a text from one of my friends who's an attorney who's on a plane right now. He does a lot of work with big corporations and medical institutes. Anyway, he's with Ben Carson, who happens to be a neurosurgeon. Many of you know. Worked at Johns Hopkins as a pediatric neurosurgeon. And they were chatting about me a little bit because Dr. Carson actually remembers when I applied to Johns Hopkins for my neurosurgery training back in 1996. That was what, 26 years ago. So I do remember my interview with Dr. Ben Carson as well, sitting in his office when I was at Johns Hopkins, considering going there for my neurosurgery training. I ended up not going to Hopkins because I chose University of Florida, which was, in my opinion, it was a better training program for neurosurgery at the time. Not that Hopkins was bad or anything, but my goal at the time was to have the best training in all the fields of neurosurgery, not just pediatric neurosurgery, but all fields of neurosurgery. And Hopkins was very heavy on spine, which I ended up becoming a spinal neurosurgeon. It's kind of funny. But they were, in my opinion, they were a little bit weak at the time on brain issues such as aneurysms, AVMs, endovascular, coiling, and embolizations. And skull base was okay, but not great. And at the time, I didn't know I was going to be a spine surgeon. I thought I was going to be a pediatric neurosurgeon. So just the thought of going to Hopkins and working with Dr. Ben Carson was exciting, but I knew that I had to keep all my options open because I didn't want to limit myself just to pediatric neurosurgery. Even though that's what I wanted to be at the time of my interviews. All right, we are wrapping this up. We're going to be done in about 5-6 minutes, maybe. And we need a little more help, Doc. All right. Can see that we're debriding the annular tear. All that stuff right there at 12 o'clock is inflammatory tissue. Shouldn't be there. It's totally abnormal. That's where all the pain is coming from, that inflammatory tissue. Let me know when I can proceed. This is the wall of the disc called the annulus fibrosus. That's where the tear is, where the herniation has come out. You can see the herniation is now gone. Remember when we started? There was a lot there. Anyway, Dr. Carson is just, my attorney friend just texted me a picture of him and Dr. Carson on the plane. So it reminded me of my time at Hopkins when I was interviewing there for neurosurgery. And I just thought I would share that experience. It was my favorite interview, by the way. They actually really treat the applicants quite well. And I specifically remember my interview with Dr. Ben Carson, sitting in his office chatting about my interest in pediatric neurosurgery. Now, in neurosurgery, there's a lot of very pretentious neurosurgeons that you're going to meet if you travel around and meet some of the most famous names in neurosurgery. But I can tell you Dr. Carson was not one of those people. He was very down to earth, very fair, humble kind of person, very appreciative of his opportunities in life, and he impressed me as just a good person. And honestly, if I had to pick which residency to go to based on one individual, I would have chosen Hopkins for him and him alone. But the reality is that I didn't want to just go somewhere for one small area of training. I wanted to be the best trained neurosurgeon in the world for everything that neurosurgeons do. And the University of Florida in Gainesville at the time was that program, which is why I ended up there. Just about done here, pretty much done. Somebody wanted to see the nerve, so the exiting nerve root will be right in that fat there, and unfortunately we're not able to see it, but you see that vein right there? That's on top of the nerve root, just below the surface. Let's go get this lateral stuff. I'm just going to zap a little bit more and we're done here. Yeah, he's not going to like that. Huh? He's doing good? Good.
We have a question.
Yeah, give me 1 second. We're almost done.
Copy.
Yeah, burned is the reason why the local didn't work as well at this disc is because there was such a big tear, it all just came out. So, you know, we're done.
You're good? All right, nice one, please.
So we're done with the Deuk laser disc repair. I will take the question, and then we're going to move on to our Deuk plasma rhizotomy.
This comes from Wanda Jones on Facebook,
Hi, Wanda.
and she asked, "Is there, excuse me, is there something that will help the annular tear heal faster than 12 months? There is a disc seal procedure performed by a doctor out of Texas using fibrin sealant. Would this help in healing the tear faster after DLDR?"
Yeah, is there the disc seal product? I do not believe in the disc seal product. It doesn't work. and I would not use it. So no, it will not heal the disc faster. In theory it would, but it doesn't. And I don't recommend it. And I personally won't use it because I don't think it's safe or effective. But it's a great question. Yep, I'm very familiar with the product and I would personally not use it. Look, you got to learn in spine, there's a lot of scams out there that are being done, and they're being promoted by venture capital firms that are investing in companies like that. Okay, and their sole purpose is to drive sales, and they have sexy ideas that don't work. We have a sexy idea that does work. That's the Deuk laser disc repair. So I don't believe in doing things that don't work on people, even though I could make a lot of money doing them. I do things that work. I'm a big believer in being honest and truthful about putting the patient's safety and well-being first ahead of profits. I would never do the disc seal procedure as it is now unless they make it a lot better, which they can't, in my opinion. There is no sealing of the disc by the disc seal, and more importantly, the cause of it, of the symptoms, is not being addressed by the disc seal. If you pay close attention, it's not the fact that the disc tear is open that's causing pain. There's another reason, which I won't go into much great detail because we already did in the video. Let's go ahead and run the video of how the Deuk laser disc repair actually works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. So now you've seen our video on why do herniated discs cause back pain and how does the Deuk laser disc repair fix back pain, cure back pain by treating the pain at the source. So hopefully the person who talked about disc seal has watched the second video and understands why disc seal won't work. Any other questions before we cut?
No current questions.
All right, well, we're done with the Deuk laser disc repair. We're going to start our Deuk plasma rhizotomy for the facet pain. We'll be back with our last surgery in about an hour. So grab some popcorn and a Diet Coke. Thanks for being a great audience.